Hi.
Hi, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glaucomflecken. This is your one-stop shop for all things eyeball-related plus. Eyeballs plus. Not just eyeballs, but mostly eyeballs. So I've got a few things to talk about today. One, first we got an Elon Musk thing, and then we got an insurance thing, and then we're going to finish the episode out with a mystery case. A rare mystery case. All right. I don't think I've even talked about this before on this podcast, even though we've been doing Knock Knock Eye episodes for a year and a half now. All right. So first off, I'm going to read you a tweet. This was said by Elon Musk over on X on December 16th. It was in response to somebody talking about MRIs. He said, widespread MRI usage done at least annually with AI reviewing the data would greatly improve well-being and mortality. These are the kinds of like absolute statements that you get from somebody who's not in the medical field. Like, if any physician said that, everybody would be like breaking down the doors, like, where's the data? How can you say it would happen? So, but let's dive into this because, okay, so for addressing the full body MRI plus AI interpretation crowd, I have questions for you. I have questions about this whole process. Okay. So let's say you go to Prenuvo or any of these companies that are popping up now that are offering this. But let's say we're at a point in the future where you get your MRI, you're totally healthy, 25-year-old, and you get your full body MRI that is then interpreted by AI. So you have this AI generated report. And maybe the report shows, oh, you have a spot. You have a spot in your abdomen. You have another spot in your lung. I have a spot in my lung, actually. So because I was getting for years, surveillance with my cancer, my testicular cancer, and they're just monitoring this little spot. So the spots happen. It ended up being nothing. Like nothing's ever come of this spot, and we eventually just stopped paying attention to it. But things just pop up. We might call them incidentalomas, which is just a thing looks a little abnormal on your scan, but does not rise to the threshold of serious concern for any kind of neoplastic process. But let's say you get your full body MRI, you're a young, healthy person, or even an old, healthy person. You're just a healthy body. And you get your AI generated report that shows you have a couple spots. What do you do then? What's the next step? All right. Do you go to your primary care doctor and be like, look, AI said that I have this could be cancer, that I need to get a biopsy. AI said I need a biopsy, which, by the way, not with AI generated things, but people are already bringing full body scans to their primary doctors. Be like, what are we going to do about this? And then what? But now we're talking with if the future turns out the way Elon Musk and his acolytes would like the future to turn out into, all right, all of this it's like basically humanless imaging process from coming in, everything's automated, the reports are AI generated, the imaging is read by AI. So you take this to your primary care doctor and maybe you convince them to send you to a surgeon. Is that surgeon going to operate on you based on an AI generated interpretation of this MRI you had done? Is the hospital where the surgeon works that owns the operating rooms, are they going to allow that kind of thing to happen? By the way, who's going to pay for all of this? And there's so many things that, like right now, I think what's happening is these full body MRIs, they're finding radiologists to interpret these, right? Like human radiologists, which is fine. We could go back and forth. Well, actually, let's talk about this. Like full body MRIs. Is this a good thing? Well, we don't know. We don't know because there's no studies done. And that's going to be the main point that I have about this whole thing, whether it's full body MRIs or AI generated reports where you just phase out the radiologists altogether and just have AI doing it all. Like we need, before we embrace any of this stuff, like we got to have data. Medicine has to be data driven. It has to be evidence based. Like we have to know that this is actually a good thing, that there's a net positive and not a net harm, a net benefit, not a net harm. And we don't have that. And I would say the vast majority of people in the medical field would guess, if you did a big randomized controlled trial looking at AI generated reports and how it compares with board certified radiologists. And I think a lot of healthcare professionals would say that doing it that way, full body MRIs for healthy people with AI generated reports, will lead to net harm. And so the next question I see a lot on social media is, well, where is that harm coming from? What are you talking about? Because there's no radiation. If there's no radiation with an MRI, there's no harm. There's no harm. Well, again, it comes back to, what do you do with that report? You have a little spot. All right. The AI generated report says this could be cancer. So you convince somebody to do a procedure on you, a biopsy, an invasive procedure. What happens if you get a pneumothorax? Or they hit an artery? You have an internal bleed. All right. You end up in the ICU. You end up with an infection from that. That's the harm, because you are taking a healthy person with this questionable thing that was diagnosed by an AI. Or even you're a healthy person, you have this thing, maybe it was diagnosed by a radiologist, but you normally wouldn't have had that imaging because there was no indication for you to have a full body MRI. But something was found, so you look into it and it ended up being nothing, but you have this horrible complication as a result of all the invasive testing. That's the harm. Like that's clear harm when there didn't need to be any harm, right? So that's where we're all coming from in the medical field. Like I don't doubt that the technology is coming. It's already here. We already have companies doing full body MRIs, but we need to evaluate this. We need like robust study. We need ironclad evidence in order to convince doctors, in order to convince hospitals to do further testing on patients that come in with this data. Like we just need to study it. That's all. I'm not saying like, no, we should not do that. Like, of course, let's study it. I would love to see the results of that. The cost benefit analysis, the harm to benefit, uh, eh, you know, we just don't have that. And so I kind of roll my eyes when I see people on social media like Elon Musk saying like, this is the way it should be right now. This is the way we should be doing it. How can you say that? You can't. You can't. Maybe 20 years from now, we will be in a place where we can say that. Sure. But we got to do the work, right? We got to do the work. But beyond all that, beyond like the potential health benefits to health costs, we have the actual monetary costs. Like our healthcare system is not built for people to want full body MRI scans and then the downstream effects from that, from a doctor appointment standpoint, elective surgeries, biopsies, evaluating those with a pathologist, all the man hours that have to happen, people that have to do work because a healthy person got a full body MRI. Like we are not built for that. Like we're already short staffed. We already don't have enough doctors. We don't have enough MRIs. If I want an MRI done within 3 months, right now, today, if I want an MRI on a patient done within 3 months, I have no other choice but to send that patient to the emergency room. For something that might not be an emergency, might not be something that emergency physicians have to see, taking up a spot in the emergency room, I have to do that because this is more urgent than 3 months. but maybe not emergent. Like a week, within a week or two would be great, but that's impossible. There's no way. There's no way to find that. So now you're going to saddle all the existing MRIs with people, healthy people that are wanting a full body scan. And I understand like some of these companies are like building their own MRIs, and that's great. Like that's the way it should be, right? If you're wanting to do this, put in the infrastructure yourself. All right. And I think they're doing that. So we need more scanners first in order to like make this a thing. But then monetarily, it doesn't make sense. Who's going to pay for all of this? Our healthcare is so expensive just to be opening up Pandora's box for any little thing you see inside your body to get it evaluated. I don't know, the time and resources and financials of that. I don't see how that makes sense right now. Do the research, build the scanners, let's get more doctors. All right, then you can do your thing, if it makes sense from an evidence standpoint. But I have my doubts. That's all I'm saying. And so hearing, seeing posts that say, widespread MRI usage done annually with AI reviewing the data would greatly improve well-being and mortality. There's no evidence for that. He's just saying it. And sure enough, 1 million people have seen that tweet. So, the demand is just going to get higher and higher for these full body MRIs. I'm not saying the technology won't be there, and maybe it will someday. But we got to study it. All right. Let's take one quick break, and I'll come back with a little insurance thing.
I will.
Yeah.
I was thinking.
What were you thinking?
Well, it's New Year.
Uh-huh.
That's the perfect time to have a fresh new outlook.
Okay. What's on top of your mind?
I love eyelid mites now.
You?
Yeah.
Eyelid mites.
Mm-hmm. I was just thinking, since they're so common, I should be more accepting.
What made you change your mind?
Well, 1 out of every 12 adults has an overgrowth of mites.
Yes, that's true.
And I know that if they happen to overpopulate and cause Demodex blepharitis, there is a prescription eye drop treatment, so no need to stress.
I love hearing you talk about Demodex. Do you like eyeballs as much as you like Demodex?
No, just the mites.
I'll take what I can get. But you're right. And so, if you ever have itchy, irritated eyelids, just go see your eye doctor. They can examine your eyelids, check for crusties, what we call collarettes, those things that the mites leave behind.
Sounds like a good plan to me.
To learn more about eyelid mites and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right, so I did something recently that I actually haven't done yet, and that is say, screw it to health insurance. I'm just going to pay for this out of pocket. In my mind, obviously, I am fully on the record to say insurance companies should go away. But I pay for health insurance. And if I'm going to pay for health insurance, I'm going to use it. And I have a lot of healthcare that's fairly expensive, especially with my testosterone replacement. And so I went to see my urologist, and I got a call from my urologist that said, your insurance company is first requiring a prior authorization. So I was like, okay. And they did it, and they submitted it, and it was denied because they just weren't sure if I had grown testicles. I don't know. Because I don't have any because of cancer, right? So I don't know. Maybe they thought, well, it's possible. Maybe they regenerate. Do they? I don't know. We're just a little bitty insurance company. We don't know. We don't know that thing. It's possible. Is it possible? Maybe it's possible. So that's what they're thinking, I guess. I don't understand what other conclusion they could come to deny a testosterone replacement that I've been on now for years. I get every 3 months, and all of a sudden they're like, don't think so. And so I was like, okay, let's do an appeal. And meanwhile, I'm overdue for my testosterone. I'm starting to feel like crap. My mood is in this tanks. I start feeling a little depressed. and I'm irritable and tired all the time. Just awful. It's just awful. And I've been through this a number of times now, so I know what that feels like to be have low testosterone, and especially when you don't make any yourself. And then another appeal was denied, and now we're going on like a month. I'm overdue, and at that point, I just say I say screw it. Like, what does it cost? I'll pay it. I'll pay it. And you know what? That is exactly what the insurance companies want to happen because I'm still paying my premiums. They're getting their money every month. The best thing for them is that we don't use the insurance for our healthcare. And so, but I did it because I was tired of it. And you know what? I have no regrets. Like 3 days later, I got my testosterone. Yeah, I paid more for it, but I got it. And it was honestly, it was like it was freeing in a way. Like I loved it. Now, I have the privilege of being able to afford that, right? Not everybody can. And that's the problem because we are inextricably linked to health insurance right now. All right. We expect it as part of our benefit package. Employers have to provide it. Well, they don't have to, but it's expected. And we're paying our premiums, so we're going to use it. But I honestly, I more so now than ever, I'm like pro like cash, like just cut that out. And I've been hesitant to like throw my weight behind and my platform behind like direct primary care and concierge medicine and all these ways of cutting out health insurance. But and the reason is because like I understand that that's not an option for a lot of people. That's not an option. But man, I don't know. My walls are breaking down and I'm like, God, well, maybe that's just the way we gotta we have to think about it because I tell you, the idea of just like knowing how much something is gonna cost, planning for it, paying for it is is a wonderful thing. But what happens if you need chemotherapy? Right? What happens if you get in a car accident? You have like 30 broken bones. Like our healthcare, it's too expensive. And so we have to have some insurance. We have to have some way to pay for all these. And people talk about like catastrophic plans and things, and it's a reasonable thing. A lot of insurance carriers don't offer that because they kind of like the status quo, right? So I don't know, but I enjoyed the cash pay. We do that with some we have some psychiatry help in our family, and so a couple people in doing therapy, and we pay cash there as well. And so it's just it's so simple. It's so simple. The problem is like so much of healthcare is not affordable to be able to do that. And so how do you? I don't know. It's just too complicated. But I just wanted to say, I see you, all you DPC, all you direct primary care folks, and I get it. I absolutely get it, and I'm sure that is freeing for you as well on from the physician side of things. Oh, it would be so nice to just like, hey, this is what this costs. Pay it, and we'll do it. We'll go from there. And it's just like it's on now. It's all a guessing game. Everyone is just it was just guessing how much things cost. Even hospitals, they set prices. We don't know what they are, but usually they're crazy high, way higher than it would be if we did not have health insurance. Whew. All right. Anyway, uh, that's it. That's it for that. Should we get into our case? Let's do that. Let's do. I ask you like you're sitting here in the room with me. I'm sure you're probably ready for it. It's the holiday season. Oh, it's kind of after holidays at this point, but still, it's still the magical time of year. We shouldn't be downers. Let's be uplifting. So I have a harrowing case, but it has a good outcome. I'll go and spoil that for you. All right. So here we go. Let's do this. Let me pull it up here. All right, here we go. So we have a patient, 68-year-old man, who comes in with 6 months of persistently blurry vision in his left eye. No pain, not having any flashes of light, no double vision, noticing a few floaters. So blurry vision, a few floaters. Okay, so I hear that, first of all, like what's top of my differential? It's happening in one eye, blurry vision with some floaters. Okay, could it be a retinal tear, retinal detachment? Obviously, that's like, okay, that's most common things being common, right? 68, this is classic time in someone's life for a vitreous detachment, that vitreous jelly, that vestigial structure filling the back of your eye starts to degrade and pull off of your retina and put traction on the retina, give you little flashes sometimes, but then also give you floaters as it condenses into spots, dots, strands, spider webs, clouds. People have all kinds of it. Sometimes they say it looks like a person. I don't understand that. It's like a cloud, seeing a cloud shape, right? It's in the sky. It's your, where else would you see clouds? I don't know why I specified in the sky. You know what I'm saying. So anyway, that's what I'm thinking. And so comes in to see the ophthalmologist, and everything looked okay in the back of the eye. There's no retinal tears, retinal detachment. So the patient was sent home. Actually, they ended up doing a laser on the lens called a YAG capsulotomy because there's a little bit of what we call posterior capsule opacification that we can easily treat with a laser. So that was done. Patient came back, still blurry. I thought that might take care of this. Still blurry, and the floaters are worse. And so the patient was then diagnosed with a posterior uveitis. So uveitis is inflammation, an inflammatory disorder of the eye. You can have anterior uveitis, which is where the inflammation is in front of the lens, or you can have posterior uveitis, where the inflammation is behind the lens. And so that was the diagnosis, posterior uveitis. Some of the traditional labs came back like whenever you have a new case of posterior uveitis, you always think about things like syphilis, sarcoidosis, some certain autoimmune conditions, certainly infection. But this didn't look like an infection. There's no reason for an infection to occur. The patient had no recent trauma or eye surgery and didn't have any risky activities like IV drug abuse, that kind of thing. So infection really wasn't. And there's no pain, too. Usually, infection, you got a bacteria in the back of the eye. Oh, you're going to be pain. That's the big thing here. There was inflammation, but no pain. A little unusual, but it could be an autoimmune condition. That's possible. So you send those labs. Syphilis, even though I just said it's probably not an infection, but syphilis is one of those things that you have to always have on your differential because it can manifest in so many different ways. And so I've had patients that didn't have a lot of eye pain, but ended up having syphilis. And so it's always something you just check. You just check it off your list. It's the great masquerader. Sarcoid, you send ACE, lysozyme, you check for, now I'm blanking on all the other things. There's like ANCAs, even like rheumatoid arthritis. So like you send for stuff like that. All that is normal, right? So nothing showed up on the limited kind of diagnostic blood tests that you can get. And so what ended up happening, the patient had a steroid implant placed in the back of the eye to try to treat this inflammation that was causing this blurriness. It's called an Ozurdex implant. So it's just dexamethasone in the form of a pellet that you inject right into the back of the eye, lasts for about 3 months, gradually dissipates and releases steroid that can decrease inflammation. And the patient noticed a little bit of improvement. So it did get a little bit better. But after 10 weeks, when that pellet starts to really go away, uh, the patient's vision began to decrease again. And the vitritis, all this inflammation, it recurred. So now we got a serious inflammatory disorder that's not going away with fairly aggressive treatment. Putting a pellet in the back of the eye, that's a big deal. All right, not getting better, recurring. And so at that point, what you can do is what's called a diagnostic vitrectomy, where you put a needle in the back of the eye. It's a surgery. A vitrectomy is where you remove the vitreous. So you do that diagnostically, which means that you take that fluid that you remove in the back of the eye and you send it off to the lab and see what grows. And the diagnostic vitrectomy showed a monoclonal B cell population. At that point, the patient was sent from the community over to the big university because we got ourselves a case of lymphoma. All right. So, and when again, I want to reiterate. So when the patient got to the university, they did a full exam, full eye exam. Vision was hand motion. All right. Very poor vision in that affected eye. The other eye, totally normal, 20/20. Pressures were fine. Pupils were fine. Actually, no, sorry. The left eye had an RAPD. So there was dysfunction of the optic nerve in that left eye that was hand motion vision. But there was no redness. Again, patient was not in any pain, but there was all this cell in the back of the eye. The optic nerve, there were some blurred margins, so maybe a little bit of optic disc edema. And then there were these little confluent white deposits underneath the retina. So when you do a fundus exam, you can see these little scattered white spots, whitish yellow spots, peppering the macula and the mid periphery of the retina. And so at this point, top of the differential is primary vitreoretinal lymphoma, PVRL. And so on further testing of that vitreous fluid, I mentioned monoclonal B cell population that was done. And so that's pretty diagnostic right there for lymphoma. Other tests that were done, they checked for herpes, varicella, toxoplasmosis, CMV, some of the pretty rare infections that can be seen in immunosuppressed individuals, but also in some immunocompetent folks as well, but can also present with a decreased amount of pain. Like patients not really having much pain could still be these types of infections. Things like staph, strep, serratia, like gram-negative rods, those typically cause a ton of pain. Pseudomonas, like you're going to have big problems there as far as pain, discomfort. Patient's going to be miserable. So clinical course of this patient. The clinical picture was consistent with primary vitreoretinal lymphoma of the left eye. We're going to get into all about that disease here in a second. And what they had to do, though, when you see this, when you diagnose this in the eye, you can't just assume it's just primary. You have to rule out central nervous system involvement. So this patient received an urgent oncology evaluation and a complete workup, including, speaking of MRIs of everything, MRI of the brain, PET scan, lumbar puncture, basically just trying to make sure the rest of the central nervous system is clean. Fortunately for this patient, no evidence of systemic or CNS disease. Awesome. The patient still reported, vision problems in the left eye, but the right eye was unaffected. So we keep a close look at that right eye on the fellow eye to make sure that eye doesn't have problems. The patient initially opted for systemic chemotherapy. So we'll talk about that in a second. Wait, there was no systemic disease. Why did this patient get systemic chemotherapy with methotrexate and rituximab? Well, we'll talk about that. Combined with intraocular methotrexate. That's right. You can put chemotherapy right into the back of the eye because that's where the disease is. This is primary intraocular lymphoma. Patient tolerated it well. 2 cycles of chemotherapy. The patient eventually declined further systemic treatment and just continued with intraocular treatment alone because, as you can imagine, there's a lot of surveillance that goes every few months. You're coming in for PET scan, MRI, and still, over time, no evidence of systemic disease. All right, let's just stop the systemic chemotherapy and just continue treating the eye. So receiving intravitreal methotrexate twice a week for a month, then weekly for a month, and then monthly thereafter. So you taper down a little bit, but you keep that going potentially for years. Throughout the course of this treatment, the vision for this patient gradually improved to 20/30. Hand motion, severe disease, tons of these white blood cells, these monoclonal B cells, and then gradually improved with treatment to 20/30 in that left eye. Amazing. Amazing. That you can drive with that 20/30 and remain stable without signs of lymphoma recurrence at 9 months of follow-up. And this was a case that was published. The patient continued to receive those monthly injections and 3-month brain imaging, or brain imaging every 3 months. All right, so primary, let's take a break. That's the case. Great outcome. Yay. Patient survived. Doing well, I think. I don't know. We don't have follow-up beyond that, beyond like a year, but let's just say he's doing great. Let's come back and we'll talk about primary vitreoretinal lymphoma. Okay, so PVRL, primary vitreoretinal lymphoma, it is a very, very rare. This is a true zebra. Not even zebra. This is a unicorn. Are we sure this exists? Yes, it exists, but it is that rare. It is a high grade malignancy of B cell origin and can have a poor prognosis if there's systemic spread because it's high grade. All right, this is not your average B cell lymphoma. This is a bad B cell lymphoma. The lymphoma originates from the vitreous or the retina. And it's classified as a primary intraocular lymphoma. Among intraocular lymphomas, because you can have several different types of lymphomas in the eye, this one is the most common, but it's extraordinarily rare. It comprises less than 1% of all intraocular lymphomas. Take all the intraocular tumors. So take all the different types of tumors that can occur in the eye, melanoma, metastases from breast cancer, brain cancer, other things like there's different types of like retinoblastoma, all these things. So primary intraocular lymphoma makes up less than 1% of all of those. And it's estimated to affect fewer than 2,000 patients in the US annually. So it just gives you an idea how. So we don't have a lot of studies looking at how to treat primary intraocular lymphoma. And that gets to how this case was approached. Okay, so the clinical features of this disease, it can be wide ranging, but most of the time you're going to have blurred or hazy vision because think about it, you're looking through these sheets of white blood cells that are not supposed to be there. It's going to cause a little bit of blurriness. People can have floaters. Painless vision loss, though, is classic. These patients do not have pain. Not any pain, just blurriness and floaters. All right, maybe some flashes. Less commonly pain. If the lymphoma has spread to the brain, it often grows extremely rapidly. It can cause neurologic symptoms, cognitive decline, behavior changes, hemiparesis, ataxia, seizures. That's why when you diagnose this as an ophthalmologist, which I actually have never done, I've not seen this, or at least I don't think I've seen this, you have to institute the systemic workup immediately. This is because we're talking life and death here. Once it spreads outside the eye, it's almost game over. It's really, really a challenging disease. So on your eye exam, you're going to see all that vitreous haze and cells floating around back there. It can, just like it was in this case, it can masquerade as just your run-of-the-mill posterior uveitis, because there's so many other things that it might be when you see cells and inflammation in the back of the eye. All right, this is not second, third, or fourth on your differential. Primary intraocular lymphoma is 10th, 11th, 12th. It's low down there, but it is something you have to think about, especially if and it's reasonable. Like in this case, it was totally reasonable to treat this as a posterior uveitis with intraocular steroid. But if the eye doesn't react the way you expect to that treatment, that's when you start thinking about other possible diagnoses like PVRL. The yellow spots that I mentioned that were seen in the retina, that's because the diseased vitreous cells, these B clonal antibody, whatever I'm saying, the B cells, monoclonal antibodies, they can infiltrate underneath the retina into the retinal pigment epithelium and form those flat, creamy white lesions. And that's, again, dangerous. You got to get this treatment going because it can continue to burrow out of the eye and get into the systemic circulation. Then you're really in trouble. And so let's talk about treatment because I mentioned this patient was treated with systemic therapy as well as intraocular therapy. We don't have any data because there's so few cases of this. Again, less than 2,000 people every year. It's really hard to run a randomized controlled trial looking at, okay, do you include systemic therapy even if there's no sign of systemic disease? Do you just treat the eye? Do you treat both? That would require a randomized controlled trial to determine what is the best option and what medications do you use. And there's just, it's so difficult when you have so few people that come in with this disease. And so in this case, it's a discussion with the patient, right? Well, we don't see any signs of systemic disease, but because our knowledge is relatively limited, do you want to go ahead and just kind of prophylactically do a round of chemotherapy, do 2 rounds of chemotherapy, just in case there's a few, even 1 or 2 little lymphoma cells that manage to find its way out of the eye and start circulating around. I think me personally, if I was healthy enough to tolerate that kind of systemic chemotherapy, I'd probably go for it. But that's one of those evidence-based discussions that you got to have with your doctor. Hopefully your doctor's seen a case or 2 of this. This is why AI will never replace physicians, at least not completely, right? We need to have these types of conversations when we're on the edge of scientific discovery with rare diseases. Like, we got it. It's not cut and dried. There's no right answer here because we don't have the evidence to tell us what the right answer is. So this patient, couple rounds of chemotherapy, decided, okay, nothing has shown up on the systemic surveillance testing, so let's just focus on the eye. And so intraocular methotrexate or rituximab, we don't do ocular radiation very much. So the times when we'll do direct radiation to the eyeball is really just with melanomas. And it's an incredibly exact science. You measure the size of the melanoma tumor in the eye, and you actually have a radioactive plaque made specifically to that tumor's dimensions. 5 millimeters by 6 millimeters. All right. And you're creating a plaque that perfectly aligns with the dimensions of that tumor, and you're suturing it onto the outside of the eyeball right where that tumor is, delivering very focused radiation. It's incredible. I've seen this happen. I had a mentor in residency who was like one of the preeminent ocular radiation melanoma specialists, because Iowa has a lot of melanoma. And it's amazing. So it's not just like you point the beam at the eye and go, no. But it's not done for primary intraocular lymphoma because that's the way you'd have to do it. You'd have to just like point the beam at the eye because the cells are everywhere. They're filling the back of the eye. There's no way to localize that treatment. So, and the potential negative effects of radiation, whole eye radiation, are awful. Like, the eye basically wouldn't survive. So we focus more on chemotherapy, allowing a patient like this with terrible vision to all of a sudden start gaining some of it back, 20/30, and survive. Great. That's primary intraocular lymphoma. Primary vitreoretinal lymphoma. Sorry, PVRL. That's Knock Knock Eye. I hope you enjoyed that mystery case. I don't know if anybody of you all will ever see it. I might never see it myself as an ophthalmologist, but at least now it's somewhere in your brain, so there you go. Thank you all for listening. Again, I am your host, Dr. Glaucomflecken. Check out my YouTube channel, by the way, at Glaucomfleckens. That's where all the podcast episodes go. Leave a comment. If I said something wrong, sometimes I screw up, or you have something to add, or if you know someone that's had this disease, like I would love to hear what you have to say. You can either email us knockknockhi@human-content.com or leave a comment on the YouTube channel. All right, I look through all those comments and try to, every now and then, share some of the best ones with you. And so, leave a comment. Oh, throw a subscription there. Subscribe to the YouTube channel if you want to. And thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Brook. Our editor and engineer is Jason Pertiza. Our music is by Omer Benzvi. Knock Knock Hi is a human content production. I'm going off memory. I don't have it in front of me. That's it. All right, we'll see you next week, everyone.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.